Okay, I think it's 11:31 a.m. with my time. Good morning or good afternoon, everyone. Thank you very much for joining this fall Prevention and Epidemiology Committee meeting. That is hopefully the last time we are meeting virtually. We are so excited to see each other again in 6 months in Seattle this time. So in behalf of my co-chair, Dr. Marian Neuhauser, I would like to welcome everyone officially to today's meeting. We have a full and packed agenda with exciting updates and new studies. And I will give the floor to Dr. Neuhauser now to introduce our guest speaker.
You could click through the next few slides so that we see our agenda. And we do have a small change in the agenda. Dr. Zell is not able to join until later, so we've switched him out until later. And you can click through the next slide. And the next one. It's my pleasure to introduce Dr. Richard Ha, who is an associate professor of radiology at the Herbert Irving Comprehensive Cancer Center at Columbia University. Dr. Ha completed his residency at Mount Sinai and his fellowship at Memorial Sloan Kettering. Dr. Ha's research focus is on using artificial intelligence in breast imaging. This is a really exciting area with many possibilities for screening and diagnosis. And his presentation is titled Harnessing the Power of Artificial Intelligence and Novel Technology to Assess Breast Cancer Risk. We may have some time for questions at the end, but please put your questions into the chat and we will monitor those. And Dr. Ha, I want to welcome you to the virtual podium.
Great, thank you so much. Thank you everyone for this kind invitation. So the title of my talk today is Harnessing the Power of Artificial Intelligence and Novel Technology to Assess Breast Cancer Risk. And I am from Columbia University Medical Center in New York City. No relevant disclosures. So in the next 20 minutes, I will focus on talking about our research in terms of applying deep learning for developing a risk model using a mammographic data set. I'll also be speaking about novel chemo prevention agent. We just completed a study and I'll be sharing that data. And then third and lastly, I'll speak a little bit about our novel technology using diffuse optical tomography. So breast cancer risk assessment. Why is this important? Certainly there are screening implications. When do we start screening for breast cancer? At age 40, 45, and 50. And then there is some variability depending on an organization's recommendation. And do we do this every year or every 2 years? But everyone would agree that earlier and more frequent screening would be important if one is at high risk for breast cancer. So the question really is, how do we assess breast cancer risk? There are clinically validated models like BCSC, Gale model, Terekusic, which you input family history, age, menarche, BMI, and other data to give one's risk for breast cancer. Certainly genetics play a role. BRCA, perhaps the most well-known mutation that increases individuals' risk for breast cancer. But how good is it? So it turns out in clinical and genetic data account for about 20 to 25% of patients that develop breast cancer. So by that, majority of the patients, around 75 to 80% of the women who develop breast cancer have no known clinical or genetic predisposition. So how can we better stratify individuals' risk? there is potential for imaging biomarker to contribute to better risk assessment. So perhaps the most well-known imaging biomarker of breast cancer risk is mammographic breast density. As many of you are aware that if you have fatty breasts compared to dense breasts, patients with dense breasts are 3 to 5 times higher risk for breast cancer. Is this useful? Can we use this to stratify individuals' risk? So it turns out if you look at the breakdown of breast density, women with different breast density in New York, in the United States, 10% of women have fatty breasts, 10% have extremely dense breasts, and about 80% are classified into the middle 2 categories. So in essence, half the population have dense breasts, what we consider to be high risk. So certainly not all women with dense breasts are high risk. So the idea is patients with dense breasts are truly high risk and some are not. So we begin to investigate this using advancements in AI to identify distinct features associated with breast cancer risk. So here's an illustration. 2 patients, patient 1, patient 2, their mammographic images performed in 2012. And then the idea is 5 years later, can we predict, patient 1 developing breast cancer while patient 2 remaining negative for breast cancer. And both of these patients are mammographically heterogeneously dense. Both patients have no family history or genetic predisposition. So we used mammographic data, trained our algorithm to be able to pick out distinct features within the mammogram to predict accurately that patient 1 developing cancer 5 years subsequently, while patient 2 remaining a low risk and did not developing breast cancer 5 years later. So we published this data using about 1,500 images. And then subsequently, a year later, in a larger study using 72,000 images, confirmed our finding that mammographic features can be predictive of breast cancer risk. So, again, with our 1,500 cases, it was a preliminary feasibility study. And so subsequently, we did a larger number of cases, about 20,000 new unseen data in a prospective blinded evaluation. And another thing that we did is we combined it with the clinical risk prediction model, PCSC model, with our hypothesis being that if you combine the CNN model with the clinical model, that you should improve the AUC. Here's an AUC curve from the study. So when you combine the CNN model with the PCSC model, the combined graph is shown in purple. So it does have that synergistic effect to improve your predictive model. And then it turns out the patients that perform the best are young patients under age 50. And then the demographics are representative of patients in our near our institution, which are predominantly African American and Hispanic women, and it was reaching AUC of 0.79. So again, the idea of combining clinical data with imaging data to improve the predictive power and increasing the AUC. So we have shown that there is potential utility in general population to predict risk for new breast cancer. And the second question that we had is it possible to predict breast cancer relapse in patients with personal history of breast cancer? So we apply this to this population with personal history of breast cancer. So mean CNN score on the left, and then the red line indicates group of patients that had relapse, and blue line indicates groups of patients that did not relapse. And there was statistically significant difference and higher risk score based on our AI in patients that relapsed versus the patients that did not. So the third question is, we wanted to see if our AI algorithm was modifiable. Can it be used to monitor treatment response and test new chemo prevention strategies? So here are some figures from our published paper. So we applied this to a group of patients that underwent tamoxifen treatment compared to those that did not. So this is patients that, this is an example of a patient that did not go tamoxifen treatment. When you compare A to B, which is A is baseline and B is follow-up, and C and D is our AI algorithm. The areas that are yellow to red are indicating high risk. And so if you just look at the picture, it hasn't changed from baseline to follow-up. And we compare this to the figure with patients undergoing tamoxifen treatment compared to baseline to follow-up, there is significant decrease in AI predictive risk score. Here's a box plot showing mean change in CNN score. Patients that underwent chemo prevention had significant more decrease in CNN risk score compared to groups of patients that did not have chemo prevention. So our CNN model does predict risk for new breast cancer, predict risk for relapse, and it is modifiable with potential use in monitoring treatment response and potentially testing new chemo prevention strategies. And currently, with our HOPE Foundation grant, we're going to apply our CNN model to serial mammograms to evaluate its prediction of breast cancer relapse, furthering our external clinical validation of our CNN model. Okay, so moving to the second part of the talk, another thing that we're working on at Columbia with partnering with our OBGYN group is this idea of developing a novel chemo prevention agent. So chemo prevention and birth control, about 47 million women are in the US currently use some form of birth control. And one of the common birth control is the birth control pill used by about 7 to 10 million women. And just a little background, as you guys are all aware, tamoxifen and roloxifene has anti-estrogen effects, not widely utilized, especially in young women due to adverse effects. And our understanding of how it works is that chemo prevention effects of anti-estrogen is due to their blocking the breast cell proliferation from estrogen exposure. Breast cell proliferation is also increased by exposure to progestins. And we thought another possible approach to chemo prevention would be to use an anti-progestin. So ulipristal acetate, or UPA, is a selective progesterone receptor modulator, an oral contraceptive. UPA should block the proliferative effects of progesterone and hence reduce breast cancer risk. So our idea was that it's dual acting, birth control and lowering the risk for breast cancer. So we did a NCI supported randomized clinical trial. All patients underwent baseline assessment, put into two arms, a control arm and an UPA arm. And then we did a post-treatment assessment. So the outcome measure was this: after being in either the control or the UPA arm, we wanted to measure the breast cell proliferation, both using a tissue core biopsy sample and breast MRI, which tissue, a patient underwent breast biopsy, taking on the average of 10 cores, and send out to pathology where they quantified the Ki-67, which is strongly associated with breast cell proliferation. And we did a second outcome measure using MRI, breast MRI, background parenchymal enhancement. And we did this in two ways, both qualitatively and quantitatively. Those of you who may not be as aware of breast MRI background parenchymal enhancement, back in 2011, there was a publication that showed association with breast cancer risk with how much background parenchymal enhancement is present. Here's an illustration. Image on the left is minimal. Image next to it is mild, moderate, and marked. So these are the gradation of background parenchymal enhancement that you can see, and more background parenchymal enhancement is thought to be associated with increased risk for breast cancer. So these are qualitatively assessed into 4 buckets, 1, 2, 3, and 4. Minimum, mild, moderate, and marked, and they tend to be subjective with inter and intra-reader variability. So blinded evaluation for these are essential. Given the subjectivity, one of the things that we also sought out to do is using the technology to automate the process, making it quantitative, which tend to be objective, and the output is a continuous variable rather than putting into the 4 buckets. Here's an illustration. So a patient on these top 2 images, A and B, which is a pre and post contrast, and putting this into our algorithm, which automatically calculates, identifies the area that's fibroglandular tissue, and within the fibroglandular tissue, it identifies the area that's enhancing and is able to give you a precise quantification. So here on the top image is 16% background parenchymal enhancement. And on the bottom is another image with patients with a larger degree of background enhancement, and our algorithm had predicted this to be 62%. So here's the results of our study. First, talking about the control arm. So control arm, both Ki-67 and background parenchymal enhancement, either qualitatively and quantitatively, there was no significant interval change. In the UPA arm, as we hypothesized, compared to baseline and subsequently going on the UPA arm on the post-treatment outcome measure, there was significant decrease in Ki-67 as well as MRI BPE measured both qualitatively and quantitatively. So, you know, our results indicate that there is clinical potential. Progesterone receptor modulator, which can be used as an oral contraceptive, can act as a dual birth control and potentially lower risk for breast cancer. So this is the last part of the talk. When we think about ideal machine for measuring breast cancer risk, some of the items on the wish list is that, you know, it should be very comfortable for the patient, rapid, you know, ideally no radiation, no IV injection, and performed in a relatively short period of time. And one of the technology that we have experience here at Columbia is diffuse optical tomography, and the 2 rings is, you know, where the breasts are inserted, and the image on the right shows a woman being measured by the diffuse optical tomography. Just a little background, it's able to image the whole volume of breast simultaneously using a low intensity near infrared light, measures tissue concentration of oxyhemoglobin, deoxyhemoglobin, and water percentage. We published a paper titled Diffuse Optical Tomography of the Breast, a Potential Modifiable Biomarker of Breast Cancer Risk with Neoadjuvant Chemotherapy. And these figures are summarized here on the left. These are the mammographic density, fatty, scattered, heterogeneous, and dense. And our diffuse optical tomography images showing a similar level of oxygen hemoglobin concentration as you increase the breast density. And then the figure on the right does show modifiability with neoadjuvant at baseline compared to at the end of the neoadjuvant. There's a significant decrease in measurable oxyhemoglobin by diffuse optical tomography. So some things to consider, certainly, mammogram has its potential. It's widely used. The mammographic data is available. The breast density, is a very well-known biomarker. And now applying AI to the breast density data, I think we're able to get more precise in the individual level. And then breast MRI is also with the BPE, now that we have a way to quantify it. So that can also be a good tool for breast cancer risk assessment. And a new technology such as diffuse optical tomography also has some promise in assessing risk. So this is my last slide. So sort of summarizing, the potential value of imaging. So as radiologists, we deal a lot with images, and it doesn't have to be a mutually exclusive thing. I think if we could add value, if we could generate data that's helpful, and I think we believe that we could combine with all the valuable data that we could get clinically, and with the combination of both, we could really contribute toward a precision medicine for that individual. So acknowledgement, a lot of our work has been done with our medical oncology group, Dr. Kathy Crew and Dr. McGinnis, and our study with looking at UPA as both oral contraceptive as well as risk-reducing agent is with Dr. Caroline Westoff, and some of our colleagues that's been important in developing our AI algorithm, Dr. Jamba Wallaker, Dr. Zhao, Dr. Liu, Dr. Chang, and Dr. Mutasa, and Dr. Schwartz, our radiology chairman, who's very supportive of our research efforts. So I'll stop there and happy to take any questions.
Dr. Ha, thank you so much. That was really quite an outstanding presentation, and I think this has a lot of promise. I don't see any questions in the chat, but I do have one question, and then maybe some others will have some. So the images that you showed before and after the chemo prevention, the tamoxifen, they were quite striking. And so my question is, was it a standard dose of tamoxifen? And then secondly, yes, don't advance those slides yet. Was a standard dose of tamoxifen, and what was the length of treatment? Because it was really striking.
Yeah, so I'm not aware of the exact dose, but the average time in the two groups were between 3 to 5 years is the range. And I think 3 years, most patients had minimum of 3 years of follow-up. But I think in terms of what the dosing of tamoxifen was, I'm not sure.
This is Kathy. This was a cohort of women with atypia, LCIS, and DCIS that we did this retrospective study. And at the time, we were only using standard dose of tamoxifen. So those were all women getting 20 milligrams of tamoxifen, or standard doses of raloxifene or aromatase inhibitors.
Thanks, Kathy. Any other questions for Dr. Ha? This was really very exciting. We're looking forward to hearing the results from the study that's going on now and how we might move this field forward. I really think it's very exciting. So thank you, Dr. Ha. We really appreciate your joining us today. I don't see any other questions, so we'll move on to the next study update. Now we're on our active study. So our first one is an update of S1823, and Dr. Lucia Nappi is presenting on this one. So Dr. Nappi.
Yeah, thank you very much. I'm going to present today the update of the S1823, which is a prospective observational cohort study to validate microRNA 371 in patients with early stage testicular germ cell tumors. Next, please. So in terms of background, we did select this microRNA 371 because there have been extensive studies showing that this microRNA is overexpressed in more than 90% of patients with germ cell tumors, both seminoma and non-seminoma. It's very specific for viable or active germ cell malignancy. And the only other condition outside germ cell tumors where we can actually find detectable levels of microRNA 371 is pregnancy. Among all the subtypes of germ cell tumors, the only one that it is known to have very low or not at all expression is microRNA is teratoma. So it's not a marker for teratoma, unfortunately. It is highly expressed inside the tumor cells, and it's secreted in the serum and plasma. And the concentration and the expression of these microRNA is correlated with clinical stage. So the higher stage is correlated with higher concentration of microRNA 371 in the peripheral blood. The other very important characteristics of these microRNA is that rapidly decrease after active and effective treatment that can be after successful chemotherapy after surgery. So based on all these characteristics, next slide. In Vancouver, we designed and conducted a pilot study that was published in JCO in 2019. We are working on the update follow-up of this study. So next, please. So what we did essentially was to analyze a cohort of 132 samples coming from patients with different stage of disease. So we included patients with early stage disease, stage 1 and stage 2A, as well as patients with metastatic disease prior and post chemotherapy, and patients with residual disease post chemotherapy prior to surgery. Next, please. And what we saw was that the occurrence in predicting active germ cell malignancy of plasma microRNA 371 was much better than the CT scan and tumor markers, LDH, VHCG, and alpha fetoprotein that are the current tools that we use for management of those patients in our clinical practice. And what stand from this study was the very high specificity and positive predictive value. We didn't have any false positive sample, essentially. Also, the sensitivity and negative predictive value of the whole cohort was remarkable and was higher than, again, the CT scan and the tumor markers. This was across the whole spectrum of germ cell tumors patients that we analyzed. Next, please. So can we use microRNA 371 today to inform our clinical management of patients with germ cell tumors? The short answer is not, or not yet, because in the pyramid of validation of biomarker, we are here. So we have validated the analytical and clinical validity, but we still lack in clinical utility data. And this is why we did design S1823. Next, please. This study has a very simple question that it wants to answer, and that is, can we use microRNA 371 in the plasma to detect tumor relapse in patients with early stage active germ cell tumor, both seminoma and non-seminoma? So all the patients with the germ cell tumors are eligible for this study, but the statistical analysis is focused on patients with stage 1 and stage 2A. The patient is required to have a baseline post-tracheotomy sample, and then serial samples that will be collected during the follow-up for active surveillance, and will correlate the microRNA 371 expression to the presence or absence of relapse. Next slide, please. The patients enrolled in S1823 are divided in 3 risk categories: low, moderate, and high risk. Next, please. The schedule of the blood samples collection really depends on the low, moderate, or high risk category. The patients with the low risk disease are the patients with stage 1 seminoma or stage 1A non-seminoma, and they are required to provide 1 blood sample for microRNA testing every 6 months during their surveillance for 3 years, while the patients with moderate risk allocation are required to provide blood samples every 3 months during their surveillance schedule. Next. Patients with high-risk disease, who are patients with metastatic disease who are treated with systemic chemotherapy, surgery, or radiation therapy, are asked to provide a baseline sample at the time of diagnosis, pre-active treatment, post-treatment, or pre and post-surgery, if surgery is also something that is pursued after other treatments, such as chemotherapy or radiation. Next slide. These graphs summarize what we are requiring and asking for S1823 is overall a very low burden of work in terms of site commitment and also patient's commitment. So we require both a baseline post-tracheotomy or pre-active treatment sample, and then additional samples during the surveillance. The tubes that we required for the blood collection for the microRNA 371 are Streck tubes that are usually coming from the sites, but SWOG will reimburse the cost for the Streck tubes. And then the samples at room temperature are required to be shipped to Nationwide for acceptance login and banking purposes. And in batches, we'll be receiving the samples for the microRNA 371 3P analysis in Vancouver. After the analysis will match the microRNA 371 status with the clinical characteristics, and mainly with relapse to calculate and evaluate the endpoints of the analysis. So there will be no real-time microRNA 371 analysis done as part of this study. Next slide, please. So primary endpoint of this study is to establish the positive predictive value of microRNA 371 in predicting active germ cell malignancy. And I think the most important also endpoint is to establish, if at all, and by how much time the microRNA 371 expression is able to detect or precede the recurrence of germ cell malignancy in patients with stage 1 disease. As secondary endpoint, we are establishing, I think, the biggest clinically annotated biobank for germ cell tumor patients. We are collecting plasma, but also we are banking the Bufficod that could be used hopefully for future translational studies in these patients' population. Next slide. In terms of eligibility, the criteria are very broad. So every patient with a newly diagnosed germ cell tumor is eligible and will fall in one of the 3 categories of the study. Patients with stage 1, stage 2A or more advanced disease, or patients also with stage 1 treated with adjuvant treatment are also eligible. Next slide. In terms of statistic plan, we target 50 relapses in patients with stage 1 seminoma and 100 in patients with stage 1 non-seminoma, just because the stage 1 non-seminoma tend to relapse more often, especially if they have stage 1B compared to stage 1 seminoma. Overall, we are planning to do the statistical analysis on 806 patients with low and moderate risk and under 50 patients with the high risk disease. There are a few relapse after 3 years, so the follow-up and the samples collection will be required for only 3 years. We do plan an interim analysis at 40 relapse, so probably 18-24 months after the opening up the study. Next slide. We did activated the study slightly later than we expected because of COVID-19. It was activated centrally in June 2020. The first patient was enrolled in July 27, 2020 in the US, and the first patient in Canada was enrolled in December 2020. I think this number is wrong. I think we have reached 300 patients enrolled so far, and the accrual is going relatively well, considering that a lot of the big institution had some issues and slowed down the accrual because of the pandemic. So I think it's all considered, I think the accrual is going as we anticipated. Next slide. We are working on version 2 of the protocol, and we are collecting all the major issues that the recruiting centers sent to us. So we are going to reduce slightly the number of patients with high-risk disease, as they will not count for the final primary endpoint. And also we are reducing the number of samples that will be collected, especially for the moderate risk. We'll also modify slightly the eligibility criteria to facilitate the enrollment of the patients, and also the collection of the samples during the follow-up. Next, please. In terms of funds, we do have funds for 3 samples per patient as per SWOG policy, but we did also apply for an R01 to cover for the analytics of all the samples. And I haven't received the official letter yet, but our grant scored very well, very high, sorry. So we are waiting for the funds notification letter, hopefully come soon. Next slide. I think that's all. So thank you very much, everyone, for your support, especially to Patricia and all the Prevention Committee to support this study, and to all the people who are working actively on it, the patients that are kindly providing extra blood for us.
Thank you so much, Dr. Nappi. There was a message in the chat that there are currently 306 patients. So congratulations on this fantastic accrual. And
thank you.
Many of you probably noticed that this is, this is a really great collaboration between SWOG and the Canadian Cancer Trials Group. So it's very exciting that we have this dual country enrollment. Are there any other questions for Dr. Nappi? Okay, again, congratulations on the progress so far. On the hopeful R01, it's a great, 6th percentile is great. And also for the fantastic accrual. So now I'm going to turn it over to Dr. Arun, who will introduce our next presenter.
All right, thank you again for these lovely 2 presentations. Now I would like to invite Dr. Kathy Crew to the podium to give us an update on S1904, cluster randomized controlled trial of patients and provider decision support to increase chemo prevention informed choice among high-risk women. Kathy?
Can you guys hear me okay?
Mm-hmm.
Okay, great. So this is the study schema for S1904, also called My Choice for Making Informed Choices of chemo prevention, informed choices about chemo prevention into care. So this is a cluster randomized controlled trial, which is a limited institution study. Our goal is to enroll a total of 26 what we call recruitment centers or sites, and they will be randomized 1-to-1 to a control arm of standard educational materials on chemo prevention versus an intervention arm, which is these web-based decision support tools called Real Risk for patients and BNAV, or breast cancer risk navigation tool for healthcare providers, plus the standard educational materials. So we'll be targeting a total of 415 women who are at high risk for breast cancer between the ages of 35 to 74, with a prior history of either atypical hyperplasia or lobular carcinoma in situ. So this is a high-risk patient population that seems to derive the greatest benefit from selective estrogen receptor modulators and aromatase inhibitors, with up to a 60 to 70% relative risk reduction in terms of breast cancer incidence. And then we're also, because this is a multi-level intervention, we'll also be enrolling healthcare providers who see these high-risk women. So this may include breast surgeons, medical oncologists, primary care providers, advanced care practitioners such as nurse practitioners or physician's assistants. So anyone who manages or sees these high-risk women. And our primary endpoint is a patient-reported outcome, chemo prevention informed choice at the 6-month follow-up. And then we'll also be looking at a variety of other patient-reported outcomes, as well as actual chemo prevention uptake and adherence. And then this is part of an R01 funded project. So we'll also we have an implementation aim where we'll be assessing how these decision support tools are being implemented into their clinic workflow. So the trial was officially activated about a year ago, September of 2020. So I'll give you the update on what we've done over the past year. Next slide. So in terms of getting all 26 sites on board, we're very close. We have 24 recruitment centers already randomized and activated. So 12 in the control arm and 12 in the intervention arm. We only need 2 more sites. So if you're interested, if you see lots of patients with atypia or LCIS, these sites don't have to have like a dedicated high-risk clinic. We've sort of seen the gamut in terms of, major academic centers versus more community-based practices, and we sort of want to see the whole spectrum. Next slide. In terms of provider recruitment, so our target is 200 healthcare providers, and we're up to, I believe it's now up to 112 providers, so more than halfway through with recruiting providers out of a total of 19 sites that have been activated. And we've also been conducting, as part of our implementation aim, pre-implementation interviews just among providers who were enrolled in the active intervention arm. So we've already completed 22 provider interviews, and our target is 30 total. So provider recruitment has been going very well. You can see the sites that have been the most active in terms of recruiting providers. And I believe just this week, 2 more providers from Kaiser that just activated were also enrolled. Next slide. So in terms of patient recruitment, I mentioned that we were activated in September of last year, and we started recruiting patients around January of 2021. And thus far, 11 sites have started actively enrolling patients. And as of October 1st, there were 70 patients enrolled. As of this week, we're up to 75. And because there's gradual activation of the sites, our goal was actually to recruit 10 to 12 patients per month when the first 12 sites were activated. And then once we get to all 26 activated, reach an accrual goal of 20 to 24 patients per month. So we have less than half the sites activated, and more recently we have been averaging about 10 to 12 patients enrolled per month. So I think the biggest barrier thus far in terms of boosting up our patient accrual, because we're a little bit behind, is more getting the sites activated so that they're prepared to start enrolling patients. But I think that one of the things that we've been doing to engage the sites is holding monthly calls or Zoom meetings with the study personnel from all of the recruitment centers. So that has helped to get people engaged and also figure out, some of the logistics in terms of getting the sites to activate. Next slide. So the other barrier that we've identified is that, so of the patients in the intervention arm, so close to 80% are logging into real risk, but our completion rate of the actual tool has been suboptimal. It's only about half of them that are completing all the modules. So we have been talking to sites in terms of things that we can do to address this. So one is just timely submission of all of the baseline data and entering that data into RAVE, because we use some of that breast cancer risk information to populate the Real Risk app. So I think the sites have gotten a lot better in terms of, as soon as they enroll the patient, getting all that baseline data entered so that we can then send the login credentials to the patient so that they can access the tool right away. The other thing that we've done is give demo accounts to all of the sites so that even if the patients can't log in immediately when they enroll, they could get like a quick, navigation through the tool just so they know how to log in and how to access the tool. We also wanted to remove, access to technology as a barrier to recruitment. So as part of the R01 funding, we have put in that we could provide iPhones or even tablets to the sites to, because this is a tool that could be viewed on a computer, on a tablet, on a smartphone, and it is available in English and Spanish so that, that we can remove language as a barrier as well. And then because we can track here at Columbia when patients and providers actually access the tool, we can view in the back end what the completion rates are. So we've been sending monthly reports to the sites in terms of the completion rate because, the research coordinators at the sites have the personal relationship with the patients and providers and can send their own reminders. And then the other thing that we've done is to try to just decrease the burden and really focus on the modules that are most relevant for the patients that are enrolled in the studies. If you go to the next slide, this is a screenshot of the main page of the Real Risk app, which the intervention sites would see. And so the ones that are most relevant for this chemo prevention trial is the module on breast cancer risk factors, where they'll actually input some of their breast cancer risk information. And one thing that we did, we send the patients, patients and providers URL to access these sites, but we've been using what's called a FHIR API for the Real Risk app. That's a fast healthcare interoperability resource application programming interface. So for sites that use Epic as their EHR, patients can actually, when they log into that module, can actually then be sent to their patient portal and can then download their health information into the Real Risk app. So we've been doing some work, actually, Julia McGinnis, who will be speaking shortly, has been doing work to collect demographic information, some family history, breast density from the mammogram report. So we can now automate some of that extraction of clinical data from the patient's medical record, which can then be used for the risk models that we've already built into the tool, such as the Gale model and the BCSC model. And then the other major module is the one specifically on chemo prevention. So it takes about 10 to 15 minutes to complete each of these modules. You don't have to do it all in one sitting. And then once you complete at least those 2 modules, then you can also get a summary of all of your interactions through RealRisk with the action plan that they can print out as a PDF. Next slide. So we move on to the next slide. So we just had revision 4 to the protocol approved, which added 2 additional recruitment centers. One thing, feedback that we got from the sites is that we set as a window for doing the follow-up assessment a 6-month clinic visit, because it's sort of standard of care that these high-risk women get seen every 6 to 12 months in the clinics. But some of the sites were saying, well, some women were making the decision about chemo prevention sooner. So we just increased the window so that they can be seen anywhere between 3 to 7 months after registration for that clinic follow-up, which can be done virtually. It doesn't have to be an in-person visit. So some of the things that we're thinking about for the next revision, so hopefully we can get those last 2 recruitment centers randomized and put on the next protocol modification. We should be finishing our pre-implementation interviews soon of the providers. And so we're preparing to also do mid-implementation interviews of up to 30 patients who are enrolled in the intervention arm, just to get their feedback in terms of what was helpful with the tool or what was not helpful. And so we wanted to also decrease the window, because initially we were going to do that at 1 year, but we wanted to link it more closely to that 6-month follow-up visit. Some of the sites were also saying, so to be eligible for the trial, you just can't have already taken chemo prevention in the past, but you don't have to wait for that 6-month study visit. Sorry for all the ambulances coming by. To actually start chemo prevention, because I think that it's not just about taking the pill. This is, a long-term intervention that women can take for up to 5 years. So I think there's still some value, even if they decide to start chemo prevention sooner, that getting access to the tool may in fact reinforce that decision or help them to maintain adherence to their chemo prevention. And then finally, some sites were coming back to us because they weren't sure if patients with borderline lesions were eligible. And I think it's part of the eligibility criteria, but we can clarify it. So basically, borderline lesions are in the spectrum from severe ADH to low-grade DCIS. So as long as it's not considered a cancer or a non-invasive breast cancer, but a benign lesion, then they would still be eligible to participate. And I think there's one more slide. So then in terms of our future plans and milestones, our goal by the end of this year is to get all 26 recruitment centers randomized. And once we have that, we plan to submit a protocol paper manuscript. We already have a draft written. And then by spring of 2022, once we have all the sites randomized, we hope to complete accrual of the providers as well as the pre-implementation interviews of providers. So we can do sort of a mixed methods paper using the survey data and interview data to really identify facilitators and barriers to chemo prevention uptake in these high-risk women. Hopefully by the end of 2022, we can also complete our mid-implementation interviews of patients and providers. And I think once we have all 26 sites activated, with an accrual goal of 20 to 24 patients per month, we should be able to complete the total accrual of 415 women within the next 1.5 to 2 years. So that's our updated goals or adjusted goals based upon just how long it's taken to get all the sites up and running. And then the last slide just has our contact information. So if there are people who are interested in opening this trial at your site, we will probably get like a couple of backup sites as well, just in case some of the sites that have already enrolled decide to drop out. But you can contact us at the email swog1904@cumc.columbia.edu. Thanks, and happy to take any questions.
Thank you so much, Kathy. I mean, you presented this complicated trial so elegantly, and made it sound very easy. And I think you laid out really the challenges and the resolutions very nicely. So it is definitely doable and will give a lot of information. So I also encourage our members to look into this, consider it, and please email. The emails are here. To see whether you would like to be a site. I think it's a very informative and important study. I am trying to look at the chat box. I don't see any questions. It's not too late. Quickly type in a question if you have any. All right, well, you have the information about the trial. So in this case, I will hand over to Dr. Neuhauser again.
Thank you, Banu. And it's my pleasure now to introduce Dr. Deirdre Hill, who's going to give us an update on the National Myodis-Dysplastic Syndrome Natural History Study. So Dr. Hill, welcome.
Thank you, and I thank the meeting organizers for the opportunity to present. Next slide. Hello, brief overview. The MDS study objectives are to involve multiple institutions and create a longitudinal biorepository with samples from participants who either have myelodysplastic syndromes, MDS, or idiopathic cytopenias of undetermined significance, which is known by the acronym ICUS. And include consistently reviewed and processed specimens is an important aspect of this study. The investigators are collecting clinical data to be linked to the specimens, and this biorepository with linked clinical data will serve as a resource to support future studies with the potential for high impact for MDS patients. Next slide. This study is an observational study of adults that meet that eligibility criteria, and participants may be followed over their lifetime. It also is a bit unique in that it is a collaboration between NHLBI and NCI, who have jointly funded the study. The goal of the study is to recruit approximately 1,750 cases with suspected MDS or these overlap syndromes. Next slide, please. And an update on the study status. Next slide. I'm happy to report that currently the cumulative enrollment is 97% of projected, and that's this yellow line here at the top, and that overall 1,450 participants of the 1,750 that were mentioned on the previous slide have been recruited into the study. Next slide, please. And beyond that, during the pandemic, the monthly rate of recruitment, which you can see on the far left in the column, has essentially held steady at 20 to 30 per month, which was the goal of the study, even though it has not met the pre-pandemic rates. Nonetheless, recruitment is holding steady during the pandemic. Next slide. How is SWOG doing? SWOG, as a proportion of all the clinical trial cooperative groups, they have recruited 624 total, of which 107 in this far right column are attributable to SWOG recruitment. We also know that SWOG has been recruiting for this study, and some of those credits have gone to other places. We've talked about this in some of our meetings, but this is good news from August. Recruitment totals, SWOG represented half of all the accruals during August. So I think there has been an uptick in recruitment by SWOG, and I want to encourage everyone to keep up this good work. Next slide. Minority recruitment has become an emphasis of the investigators on this study, and I just want to give you a brief update regarding that. Next slide. So overall, 8% of the recruits to this study have been from non-white race or non-Hispanic ethnicity. However, the study investigators realize that currently the number of MDS cases is 4% of individuals from those groups, while those groups represent 7% of NACER and 13% of SEER. So they recognize they have some more work to do to include a representative sample of non-white populations. Next slide. And this is a representation of minority recruitment by state. Continued efforts. Next slide. So I wanted to talk really briefly about scientific questions that are being addressed by this study and the findings and publications to date, because I think there's some very good work going on. It's very encouraging. Next slide. The investigators have done due diligence in publishing their study protocol and a study design. And in addition, they have conducted a fairly thorough pathology review comparing community pathologists to a centralized pathology review committee. And that's this publication here at the bottom. And they did identify some areas of need for further refinement of pathology definitions. Next slide. So this is the resulting publication where they took an area where the pathology was in some disagreement between community pathologists and centralized review, and identified 7 genes and variants in 7 genes that would help reduce the pathologic misclassification of MDS. And they were able to fairly increase the accuracy of pathology assessment. Next slide. Next slide, please. Oh, there we are. In addition, they've been collecting patient-reported outcomes, and they were able to look at frailty and quality of life. This is on the existing data with the study not being done. Nonetheless, this was the first time that quality of life issues had been assessed in MDS, and they were able to establish that MDS patients had similar quality of life issues as cancer patients. So this was an important first step. Next slide. Finally, and these are newly published papers, they were able to take that data that they were using to increase the accuracy of pathology assessment and develop a model for more precise diagnosis of myelodysplastic syndromes. This is the paper that has just been published at the top. And in addition, the clinical data and the biospecimens that were collected have been used to further develop risk prediction models so that individuals with MDS would have a better understanding of their prognosis, and beyond that, that we would have a more refined understanding of the biology of progression of MDS. And this lends some hope with that these models will have the potential for some therapeutic advances. Next slide, please. In light of all these therapeutic advances and sort of exciting work, I really want to encourage SWOG investigators to recruit for this study. Here's the site capitation details. And there's some information at the bottom for how to contact the study investigators if you have patients that might be eligible for the study. I also have this information and you can contact me. Next slide. Finally, I want to acknowledge all of the individuals who have helped lead this effort, the patient participants who are can't be thanked enough for this long-term follow-up, and finally NCI and NHLBI for funding. And with that, I'll take questions.
Thank you so much, Dr. Hill. I don't see any questions in the chat, but I will remind everyone what Dr. Hill said, that if you have patients at your site or know hematologists working with these patients, please direct them to Dr. Hill or the study directly. Banu has a question about quality of life issues during treatment.
Yes, during treatment. Does that answer your question, or were you asking for more details?
No, you had mentioned quality of life was as bad as leukemia patients. Were these patients on therapy for MDS, or just no therapy, but their quality of life was not good?
Both. Their quality of life was not good, even despite treatment.
All right. I'm trying to type one more question.
Sure.
You could also just say it if you want to.
Okay. My question was, in the denominator, do you also track CHIP, like clonal hematopoiesis? They are excluded, and then only the MDS is captured, because that's a whole area of excitement and discussion.
I believe those individuals are tracked to a separate study, a separate initiative, if they are assessed for this study and found to be ineligible.
Thank you.
Yeah, it's a very good question, Bonnie, about the CHIP. Okay, I don't see any other questions. So thank you, Dr. Hill, and I'll turn it back over to Dr. Arun.
Thank you, Marian, and thank you, Dr. Hill. Next slide, please. Actually, I'm going to give a quick update on the TMISS study. I'm the SWOG champion. It's as you know, an ECOG-ACRIN study, and not much has changed since my initial lengthy presentation. So I'll just give you updates and a reminder of the study design. Next slide, please. So this is a randomized prospective trial in asymptomatic women who present to have their annual or biannual mammograms between ages 45 and 75. Patients with breast cancer or implants are excluded, and they cannot be pregnant or lactating. The total number planned to recruit is very close to 165,000. with about 82,500 per arm. And patients are randomly assigned to either standard digital mammography or breast tomosynthesis. Next slide, please. As I had mentioned, patients can have either annual or biannual screening. The annual screening patients will have 5 screens at entry, 1, 2, 3, and 4 years, and the biennial screening patients at entry and then 2 and 4 years, so 3 mammograms. The endpoint is determining a breast cancer status on biopsies, on follow-up during the study follow-up time. And then very simply comparing the number of advanced cancers at 4.5 years between those 2 groups. The accrual is, I think, going well. It halted a little bit during COVID, as many women did not do their or delayed their screening mammograms, but they are at 55,600, as I mentioned, out of 165,000. So And there are no preliminary reports or publications that I can report at this time from the study team. Dr. Etta Pisano is the PI. So I communicated with her 2 weeks ago. This is the information that we have currently. So a brief update. Any questions? Looks like none. In that case, I'll give it over to Marion again.
Okay, now it's time for Dr. Arun to give a brief update on S1418. I think this is just an oral update.
Yes, it's an oral update. So as you know, this is a exploratory pilot study that was built off of S1418 that randomized high-risk triple-negative breast cancer patients to 1 year of placebo versus 1 year of pembrolizumab immunotherapy, PD-1, PD-L1 inhibition. And the pilot question was to see whether we see any mammographic breast density changes in patients who received the immunotherapy versus placebo, as mammographic breast density is an indicator for subsequent breast cancer risk, as it has been shown in the adjuvant trials and prevention trials with tamoxifen and to some degree with aromatase inhibitors. But we don't have any data with any other agents, especially agents that could reduce the risk of triple negative breast cancer. So this was planned to be a data hypothesis generating, pilot data generating study to see whether immunotherapy can do some type of mammographic density modulations. And the idea, of course, was that we could not do a prospective study in high-risk women and just give them pembro. So we kind of took the opportunity on an ongoing study and retrospectively review the mammograms. We had discussed this, and I know I had presented it multiple times here amongst all of the stakeholders, including CTAP, of course, DCP, of course, the PI of the study, Dr. Pustai, who was very supportive of this, and the breast committee chairs, and the translational chair in breast committee, as well as Merck, and had secured grant funding from the Hope Foundation as well. We were asked to submit an amendment to the main protocol, which got delayed because of some administrative issues, but finally it was submitted. And about 2 days ago, we've heard that CTAP rejected it. So we are going back and rediscussing and trying to re-strategize with all of the stakeholders, many of which are very supportive of this. This is my brief update on this study.
Yeah, thank you, Dr. Arun. We're hoping we'll be able to move this forward despite the rejection. So now I'll have you introduce the next speaker.
All right, thank you, thank you. All right, so the next speaker will be Dr. Crew again. I have the pleasure to introduce her. It's an amendment to S1007, effects of chemo, prevention, and adjuvant endocrine therapy on a convolutional neural network-based breast cancer risk model using mammographic data sets from S0812 and S1007. And Dr. Ha gave us a great introduction into this field. So now we know why we are doing the study and how exciting it will be. Kathy?
Actually, Julie is going to be presenting.
Yeah.
Oh, Julie. Okay, sorry.
Sorry, yeah.
All right.
So I'm Julie McGinnis.
Yeah.
I work
Okay.
with Kathy and Rich, though.
Okay.
So I'll be providing the update on these correlative imaging-based studies through SWOG. Next slide, please. So Dr. Ha did a really great job of really framing our work here. Just as a refresher, our overall objective is to evaluate these novel AI-based imaging tools as potential predictive and prognostic biomarkers among women who receive endocrine therapy for chemo prevention and also for adjuvant breast cancer therapy. And as he mentioned, we've developed a convolutional neural network or CNN-based model that we apply to digital mammograms and provides a predicted breast cancer risk score from 0 to 1. We initially did this, developed it using a training set of 737 women who were at average risk for breast cancer and were screening at Columbia, of whom we knew 210 ultimately developed breast cancer. And when we applied our CNN model to the digital mammograms that obtained at least 2 years prior to cancer diagnosis and compared it to mammographic density as well, we found that the CNN model was a better independent predictor of breast cancer risk than mammographic density, with an accuracy of 72% in predicting breast cancer cases. Next slide. And so then we next evaluated if the CNN model can show changes in predicted risk among patients who receive anti-estrogen therapy for chemo prevention. And as mentioned before, we identified 720 women at Columbia who had high-risk breast lesions, so atypia, LCIS, or DCIS, of whom 240 received chemo prevention, and then applied the CNN model to their mammograms at baseline before treatment, and then 3 to 5 years later on treatment, or off in those who didn't receive it, to assess for change. And what we found was that women who received chemo prevention had a greater decrease in the CNN score over time, which was consistent with the known benefits of this treatment in this population, and also demonstrated that the CNN model is modifiable with endocrine therapy. Next slide. And so then we recently applied the CNN model to women with early stage hormone receptor positive breast cancer who had serial mammograms and received adjuvant endocrine therapy, really with the goal of evaluating if our model could be a pharmacodynamic biomarker of response in this setting and predict breast cancer relapse. And so in this retrospective cohort, we looked at CNN scores over time, stratified by relapse in 870 women, of whom 68 experienced relapse. What we found overall was that CNN scores were consistently higher in the relapse group, and particularly as shown here, the change in CNN score from baseline to 1 year follow-up on treatment was significantly different between the groups, with a decrease seen among those who remained in remission, but minimal change among those who relapse. And also in multivariable Cox regression analysis, change in CNN score at 1 year was significantly associated with breast cancer-free interval, even after we adjusted for known prognostic factors. Next slide. The other thing that wasn't addressed as much in Dr. Ha's initial presentation was also our work with the CNN-based breast MRI Oncotype DX predictor. So we've developed this algorithm that correlates with Oncotype DX recurrence score, which as the breast oncologist will know, is a validated 21 gene recurrence score assay that provides a recurrence score and predicted benefit from chemotherapy, as well as risk of distant recurrence on endocrine therapy alone at 10 years in patients with early stage hormone receptor positive HER2 negative breast cancer. We developed this prediction algorithm for Oncotype using breast MRIs for 134 women with hormone receptor positive HER2 negative early stage breast cancer who had Oncotype DX testing and also had a baseline diagnostic breast MRI. And the CNN and evaluation applied to the MRIs achieved an overall accuracy of 81% in a 3-class prediction for low, intermediate, and high risk categories, with a specificity of 90% and sensitivity of 60%. We also, not shown here, have evaluated the algorithm among 411 patients with available Oncotype DX recurrence scores from 4 institutions using different MRI machines, and we're able to achieve similar results in predicting recurrence score. Next slide. So I'll just highlight here 2 of our studies within using SWOG data sets and imaging through which we hope to validate these initial findings in retrospective cohorts. Next slide. So SWOG 0812 was vitamin D for chemo prevention. The PI was Dr. Crew, and it investigated the potential use of vitamin D as a chemopreventive therapy among high-risk premenopausal women who were randomized to 12 months of vitamin D 10,000 units per week versus placebo. The primary endpoint here was change in mammographic density at 12 months, quantified using cumulus, so volumetric density. The actual outcome of the trial was that vitamin D did not show a statistically significantly greater change in mammographic density compared with placebo. But we actually hypothesized that our CNN model might show significant differences between these arms, given that it evaluates mammographic features beyond just mammographic density. And so we plan to apply the CNN model to mammograms obtained at baseline, and then 1 and 2 years follow-up, which were obtained as part of the study, to assess for change in the CNN score with vitamin D versus placebo, and then also compare it to the change in volumetric density with Cumulus. As shown here, there were 80 patients in the vitamin D arm and 69 in the placebo arm who had evaluable mammograms at 1 year in particular. We're still pending data analysis and the clinical data being provided by SWOG to perform that, but hopefully we'll be able to have completed some analysis by our next group meeting. Next slide. And so then the project we're doing with S1007 or Responder is to validate our findings in the adjuvant setting among women with early stage breast cancer. So as a refresher, the Responder trial enrolled women with early stage hormone receptor positive, HER2 negative breast cancer who had 1 to 3 positive lymph nodes and an Oncotype DX recurrence score of 25 or lower. And these patients were randomized to endocrine therapy alone versus chemotherapy plus endocrine therapy. And so the trial uniquely provides an opportunity to apply our algorithm to prospectively obtain breast imaging in these patients who now have long-term follow-up with documentation of clinical outcomes. So we will conduct a case cohort study within S1007 with a total of 845 cases and controls, and apply the CNN model to mammograms obtained at baseline before initiation of adjuvant therapies, and then 1 to 2 years after initiation of adjuvant endocrine therapy. And our primary aim is to evaluate if the baseline CNN risk score and change in CNN risk score from baseline to 1 to 2 years follow-up are prognostic for invasive disease-free survival, essentially validating our preliminary findings that we presented previously. And as well as evaluating this mammographic CNN model, we're also going to collect breast MRIs obtained for these patients and apply our Oncotype DX MRI-based algorithm, basically to see if we can both validate the algorithm's ability to predict Oncotype DX recurrence score, and then also evaluate at the same time if a hybrid model combining the genomic information from Oncotype DX and then this radiomics model that we've developed can further refine our prediction, specifically of distant recurrence rather than either technique alone. So right now we're awaiting protocol amendments to S1007 to get this going, and then hopefully we'll start collecting breast imaging from the participating sites through IROC. Next slide. So in conclusion, our CNN model applied to mammograms could be a pharmacodynamic biomarker of response to endocrine therapy in the chemopreventive and adjuvant settings. And we'll now hope to validate our findings using prospectively obtained breast imaging from SWOG through S1007 and S0812. And then ultimately, depending on our findings with these studies, we hope to incorporate evaluation of the model into the design of prospective clinical trials. Next slide. And so these are just our acknowledgements. I forgot to mention before specifically that our Responder study is funded as of this spring by a SWOG Hope Foundation Impact Award. Thank you, and I'm open to questions. I think I see one in the chat.
Thank you so much. This was really very, very helpful to really put everything into perspective after Dr. Ha's presentation also. Yes, there is one question from Dr. Neuhauser. How should we interpret the 0 to 1 score in terms of magnitude of association? Are there cut points considered as low risk and high risk?
Yeah, so this is a little difficult because this is sort of a dynamic thing as we apply the algorithm to more breast imaging. Initially in one of our other chemopreventive data sets, we used 0.5, so halfway between 0 and 1 as sort of the cutoff between low risk and high risk, and looked at which women changed between those groups. What we actually found when we applied it to the adjuvant cohort was that even though these women already had breast cancer and presumably would already be at higher risk than those women who just had the high risk lesions, their risk scores were actually lower. They were more on the order of 0.2 to 0.3. And so I think the issue is with these AI-based algorithms, we do expect them to refine over time. And so it's still too early for us to specifically say what does this risk score even mean in terms of predicting like X risk of recurrence. That's our ultimate hope, that we could, besides just, sort of looking for change, give a more concrete estimation of what an estimated relapse risk is. But it's still a little early for that.
Yeah, great. Thank you. I did notice that over the range of the 0 to 1, they did kind of hover between 0.225 and 0.25. And even though they looked different, just the way that the scale was shown on the slide. So I think that will be helpful moving forward. I guess you need more data for that. And I also noticed that there was greater variation in the relapse group. The bars around the estimates were wider. So that'll be something to, do further work on too. What's driving that variation? Thank you. Very interesting.
Julia, one other question.
Yes.
For the responder study, you're planning to use the MRI. Is that the preoperative MRI, and are you focused on the breast that had disease, or is it a little different than the mammogram? I guess I'm trying to understand.
It should be the preoperative MRI if they're available for these patients.
Right.
Presumably, most of them will have had an MRI at this point. Actually, Rich Ha, I don't know if you can if he's still on the line, maybe you can clarify the actual algorithm a little bit more. I think it's applied to not just to the affected breasts, but to both, but he can correct me if that's incorrect.
I think he had to go to clinic.
He had to go? Oh,
yeah.
Okay. I can clarify that with him and get back to you.
Okay. No, it'd be interesting. One of the things we're planning to do is look at local recurrence, and it may be interesting to apply this towards risk of local recurrence as well, if you are looking at the affected breast. I'll message you offline.
Okay, perfect. Thanks.
This is Kathy. I just want, because we've been talking a lot during this committee session about utilizing breast imaging for secondary imaging analysis. And I think, it still remains to be seen whether we can do this retrospective mammogram collection in a trial that's already been completed. I think one of the challenges, so for S0812, the vitamin D trial, mammographic density was our primary endpoint, and there was prospective collection of mammograms. So analyzing the breast imaging from that study was pretty straightforward because we'd already prospectively collected the mammograms. But I think the challenge, and I think that's true for S1418 as well, is that we haven't been able to convince the NCI that we can actually retrospectively collect these mammograms. It's definitely going to be much more challenging, even though these are breast cancer survivors and it's standard of care to get screening mammograms if they haven't undergone bilateral mastectomy. It's harder to do it retrospectively. I think one of the things, at least for S1007, which is already a completed trial, the responder study, Kevin Kalinsky, who is the study chair for that study, has built in some additional follow-up for patients who are still alive and in long-term follow-up to do additional blood collection for ctDNA, and we hope to sort of just piggyback off of that and say, if you have mammograms available, and through the SWOG Hope Foundation grant, we'll be able to provide some reimbursement to sites for that central upload of the mammogram images. But I know it's been a challenge for other studies, not just for S1418, but I know like the Alliance ABC adjuvant aspirin trial had a breast imaging sub-study, which has also had a lot of challenges with recruitment once the trial has already been completed.
All right, I don't see, there's one question from Leslie Ford. Have women been consented to use images? I think you partly answered that, right? In the vitamin D study, yes, but not in the other study, correct?
Yeah, so I think we should be able to get a waiver of consent to do to collect the breast imaging. So
yeah. Which was not, yeah. But it wasn't granted for S1418. So the suggestion was to, since these people come back to clinic, reconsent them. So one more challenge, sorry.
I think for the responder study, because there are patients in long-term follow-up, they had node-positive disease. Some of them may have passed away already. So I think we should be able to get a waiver of consent to get mammograms for women without having to reconsent them.
Yeah, I hope so too. That the same stands for the triple negatives, aggressive. Unfortunately, some might have passed also. Yeah. But this is, I think it's important that we discuss the challenges, of these type of studies, which at the beginning look straightforward and really will add a lot of information to our knowledge upon which we can build. But, there are challenges at multiple levels. So keeping that in mind and discussing and finding ways to work together is very important, I think, especially for our committee. If we want to do secondary analyses that, we are encouraged to do. So I don't see any other questions. So I'll give the podium to Dr. Neuhauser again.
Thank you so much. And now it's my pleasure to introduce Dr. Eileen Connolly, who's going to give us an update on the redesign of her study. So Dr. Connolly, welcome.
Yes. Thank you guys for inviting me again to continue the discussion on this study. So this is the revised proposal for what was originally SWOG 2003. So initially it was a single arm phase 2 trial, and based on DCP recommendations, we have now moved forward a redesign to have a randomized phase 2 to evaluate recurrence following intraoperative radiation for DCIS after breast conserving surgery. And the primary outcome has been changed so that we're looking at local failure, which is now defined as any in-breast tumor recurrence, either DCS or invasive disease, from the day of lumpectomy to 10 years, comparing IORT versus surgery alone. And the primary hypothesis is that the 10-year local recurrence rate for IORT will be better than surgery alone for postmenopausal women who, with isolated focus of low risk grade 1-2 DCS that measures less than 2.5 centimeters in size preoperatively. If you hit proceed, the secondary outcomes, if you move, advance the slide, are again to see if we've left in whether we can do a larger study eventually, though I don't know that they'd be interested. Collection of patient-reported outcomes, which I think are very important, comparing surgery alone versus IORT. Identification of any RT-related toxicities and physician-reported toxicities. And then we've continued to have the tumor translational medicine aim of looking at the decision RT score. This is an immunohistochemistry-based biomarker that has been demonstrated in retrospective analysis to be predictive and prognostic of the benefit of radiation after surgery alone. So we hope to look at how it performs in the setting of IORT, and then also demonstrate prospectively that it is a better predictor of in-breast tumor recurrence risk for all patients based compared to the traditional model. So next slide. So this is the redesign. Basically, now it's a randomized design, as I previously stated. We have changed our inclusion criteria to be more restrictive. So the thought was to keep this restricted to women who are 50 years and older, postmenopausal. These have to be screen detected, non-palpable, unifocal on imaging, tumors that are less than 2.5 centimeters in size, by biopsy be demonstrated to be grade 1 or 2, and hormone receptor positive. And these need to be women for whom they're surgically operable and IORT is technically feasible. Women would get randomized to have surgery alone or surgery with intraoperative radiation. All patients would be considered suitable risk by ASTRO partial breast guidelines preoperatively. Radiation would be delivered with either the Zoft or Zeiss intraoperative devices, which are somewhat comparable. And post-operatively, they would get patients would get reassessed for post-operative risk category. We expect that about 10% of patients will switch risk groups. This would be whether we find grade 3 disease, the tumor is larger than expected, 3 centimeters in size, margins are positive or close, or invasive disease is found. In which case, if high-risk features are found, they would be continue to be followed, but whole breast radiation would be offered. We expect that about 10% of patients in both arms would get whole breast radiation. Our plan is to keep these patients in analysis so that it's balanced in both arms. And our primary outcome is local recurrence, and hormonal therapy is offered. We're not requiring it, but we expect compliance to be around 50 to 70% at 5 years based on historical data. And then Decision RT, our plan is to collect tissue prospectively. The test has to be done in a prospective fashion, but our plan is not to give the score to the patients or physicians so that it does not affect treatment decisions. Next slide. This is just going over the statistics a little bit more, but our assumption is that the 10-year rate of local recurrence with surgery alone is 12%. This is based on a few studies highlighted below. RTUG 9804 showed 10-year recurrence rates of 9%. ECOG Akron 5194 showed 10-year rates of about 12%. There's other single institution studies that have higher rates. So 12% was felt to be a happy medium. And with whole breast radiation, the expected recurrence rate at 10 years is about 1.5%. Because IORT only treats the lumpectomy bed, an acceptable non-inferiority percentage was thought to be about 4%. So, and for these assumptions, you need 450 patients, assuming 10% lost over 10 years and 10% with risk group changes in order to meet our primary aim. And this gives us 80% statistical power with a one-sided alpha of 0.05. Next slide. So as far as the current status, this kind of gives the entire history of things. The last time we met, this study had been reviewed at DCP in February of 2021. It was disapproved. Main concerns were that it was a non-randomized disease design, as well as there were inclusion of patients that they felt were too high risk. Therefore, they wished us to limit patients to over the age of 50 or postmenopausal, exclude hormone receptor negative, and they wanted us to change the definition of local failure to any in-breast tumor recurrence. So these revisions were made. I did actually meet with Prelude since our last meeting, and they continue to support the study and are supportive of the redesign, though they had one concern, which I'll bring up on the next slide. And the next step is to get this to stats review. So next slide. So I should get this to stats review, hopefully after we discuss the following points, and then hopefully this will be resubmitted for executive review, and hopefully we'll get to DCP again this year. The main questions to be resolved are enrollment, should it be restricted by age or strictly by menopausal status? And I wasn't sure how this would be done, if it would require proof of menopause or how that would be done. That was one point. And then with the Decision RT, when I spoke with Prelude, they did point out that their retrospective data shows that for this, they expect in the surgery alone arm, even postoperatively, if you select for low risk patients based on strict criteria, they would expect about 10% of patients to have a high risk Decision RT score. So their question was, would that, should that be used to change management? This test has not been prospectively validated. So my thought at this point was no, that we shouldn't change management because it's not widely clinically used at this point. And I think it would make the trial more difficult if we changed the surgery alone arm to compare IORT versus surgery alone. So comments on that would be, thoughts on that would be appreciated. And then the last slide is just, I want just to say thank you, and especially to Marion and Banu for continued support, as well as the Hope Foundation for funding. I received a career award to continue working on this. So I hope to get it across the finish line.
Thank you, Dr. Connolly. Thank you for your patience and perseverance on getting this redesigned. And also thank you to Dr. Kathy Tangen for contributing design guidance as Dr. Connolly is working through this redesign. Are there questions for Dr. Connolly at this point? I don't see any in the chat. Okay, well, I'll go ahead.
The only feedback I had hoped to get was, is it reasonable to use 50 as an age cutoff, or would you be strict and say postmenopausal? And then is it okay to just leave the decision RT as it would be done, but we would not share the score? I think those are the two things I wanted guidance on.
Yeah, are there thoughts from other committee members on Dr. Connolly's two questions?
I guess I would say, I mean, if a risk score isn't validated and we're using it for research purposes, we don't have a precedent of sharing that information with the patient or the treating investigator. So I think that's very defendable.
Okay, good.
Yeah, I would agree with that. It's not, sort of a CLIA certified
Right.
result that you could normally provide to a participant.
Okay, so good. I'll leave it then.
And what about the menopausal, strict menopausal versus age 50?
For the SWOG breast committee protocols, we do have a definition we've been using for patient self-report for pre or postmenopausal, that it's a combination of age and time since last menstrual period.
Oh, okay.
And I'll just offer, and someone else may have another idea, but I think it may depend on where we see the underlying risk factors. Because that was one of the concerns of the previous review, is they didn't want anyone who was at higher risk. So if risk changes for high risk types of cancers, is that more closely related to age, or is it more closely related to menopausal status? I think teasing that out might drive what you decide to do.
Yeah. I think it's probably menopausal, but the problem is the ASTRO guidelines are based on age. So it muddies it. So.
Yeah.
In the responder study, they often were looking, and these are women with invasive breast cancer, but like when they looked at the subgroup analysis, it was cut off by age, like 50 and younger, that still benefited from chemotherapy. Determining menopausal status can be a little bit more tricky for those women who are in perimenopausal state. And really the menopausal status is really just determining whether we're going to offer them tamoxifen or an aromatase inhibitor in the adjuvant setting. So I think both are effective, and this is all, mainly for preventing a local recurrence. So it would be easier if you use an age cutoff than having to go by menopausal status.
Yeah, that's what I was thinking. Age is easier, but I didn't want to go back and get, have that be a critique again.
Yeah, and Leslie Ford just offered that in BCPT, it was based on age.
Okay.
Yeah, I think we're going to need to move forward because the clock is ticking away, but that was really excellent, Dr. Connolly. Thank you so much. And I'll turn it back to Dr. Arun.
Wonderful, thank you. So if I may have the next slide and introduce our next speaker. Julia McGuinness, one of our other investigators, will be presenting alternate dosing of exemestane among women with atypical hyperplasia, lobular or ductal carcinoma in situ. Julia.
Hello again. So I'm going to be discussing this proposal, which is more in the early stages than Dr. Connolly's. So I'll give you a little bit of background as well. So next slide. So I think, as everyone here is aware, anti-estrogen chemo prevention, including tamoxifen and aromatase inhibitors, can reduce the risk of invasive breast cancer by 50% or more among women at high risk. But unfortunately, the uptake is low, and a major reason for that is side effects from medication. And so one strategy that could mitigate the side effects of anti-estrogen chemo prevention while maintaining clinical benefit from them is lower doses of them. And we've already seen this with low-dose tamoxifen. And I'm sure everyone was aware of this study of low-dose tamoxifen, 5 milligrams daily instead of the 20 milligrams taken for 3 years reduced the risk of breast cancer by approximately 50% among women with high-risk breast lesions, including atypia, LCIS, and DCIS, compared to placebo treatment, without significantly increasing the risk of serious side effects, including thrombosis and endometrial cancer. And so low-dose tamoxifen is now incorporated into national guidelines as a chemopreventive option, but low doses of aromatase inhibitors have not yet been evaluated in this setting. Next slide. So there is an ongoing study, hopefully with results being presented fairly soon. There is an alternate dosing of exemestane study in postmenopausal women with early stage, so 0 to 2 hormone receptor positive breast cancer, in which these women were randomized to 3 arms of pre-surgical exemestane at different doses. So the 25 milligrams a day standard versus 25 milligrams 3 times a week or weekly. And they received this for 4 to 6 weeks in the pre-surgical setting before undergoing breast surgery. And their outcome here was change in serum estradiol, which is a serum biomarker of breast cancer risk, and also might, even in the adjuvant setting for these patients, demonstrate response to aromatase inhibitors. So our hypothesis is based on this study that's ongoing, and hopefully we'll have results soon, as well as the low-dose tamoxifen study that's already been presented, is that a lower dose or alternate dosing of exemestane in the high-risk population might, similar to low-dose tamoxifen, provide similar benefit to the full dose of exemestane. Next slide. So what we're proposing a randomized controlled trial of alternate dosing of exemestane for chemo prevention among patients with atypical hyperplasia, LCIS, or hormone receptor positive unilateral DCIS. These patients would be randomized 1-to-1 to either exemestane standard dose, which is 25 milligrams daily, or an alternate dose, which we still are awaiting the results of this pre-surgical study to determine. It would either be once weekly or 3 times a week, depending on the results of that study. For those patients with DCIS, they'll be randomized to treatment after completion of definitive breast surgery, plus minus adjuvant radiation when appropriate. And another aspect to be determined that is still going to be discussed is whether or not this trial will be truly blinded. If it is, we could consider using blister packs as in previous trials, including the pre-surgical exemestane. If we decide not to blind it, we could actually at the same time gather some real-world adherence data as part of this trial as well, but again, would lose the benefit of the blinding. Next slide. So in terms of inclusion criteria, women will be postmenopausal by NCCN criteria. And as I mentioned, have atypical hyperplasia, LCIS, or hormone receptor positive DCIS. And for those with DCIS, have completed their definitive local treatments. So patients will be excluded if they have a history of prior invasive or non-invasive breast cancer, or prior treatment with an aromatase inhibitor or other anti-estrogen therapies, including tamoxifen for chemo prevention. Also, just given the nature of AIs and this being a chemo prevention study, we'll exclude, similar to the pre-surgical exemestane study, those patients with severe osteoporosis in the weight-bearing skeleton. Also, for reasons I'll get to in a second, we're going to exclude patients with bilateral mastectomy as we're hoping to also do some imaging-based correlative studies. Next slide. So similar to the pre-surgical exemestane study, we're hoping to use a serologic or a serum-based biomarker, serum estradiol, at 1 year as the primary outcome, hopefully to decrease the length of study follow-up required to provide results. And as I mentioned before, this is based on evidence that serum estradiol contributes to breast cancer risk, and also that change in serum estradiol at 6 to 12 months in patients who receive adjuvant AIs for early stage breast cancer can predict distant recurrence in particular. And so we'd be measuring serum estradiol using an ultrasensitive assay, so we could detect it at levels below what is typically measured with a standard assay. And we'd be measuring it at baseline in 1 year, looking for change over that time as, again, our primary endpoint. And secondary endpoints being breast cancer incidence, both invasive and non-invasive. We're also hoping in this study to incorporate our mammogram-based convolutional neural network model that I just discussed and apply it to serial mammograms obtained during follow-up on the study. This is why we'd be excluding patients who have had bilateral mastectomies and wouldn't be having mammograms during follow-up. Also of importance is looking at toxicity amongst the two arms, particularly menopausal symptoms and arthralgias, adherence using PROs, as well as other markers, including change in metabolic markers at the different doses, such as lipid profiles, glucose, et cetera, given the potential effect on metabolism with AIs, and then also looking at change in bone density and serum markers of bone turnover. Next slide. So as I mentioned, we're still in the early stages of development with this, and actually based on feedback from a prior call have continued to update this and expand our population from DCIS to the high-risk population I described. We're still awaiting the results of this pre-surgical exemestane study to determine that best alternate dose, either weekly or 3 times a week. I'm also going to further develop this concept at the SWOG Young Investigators Training course whenever the new date is announced this year or early next. And then ultimately, based on feedback from that course and ongoing discussion with this group, submit a 10-page concept to the NCI for review. So I'm open to any feedback, especially about some of the issues that I brought up with blinding, et cetera. Let's see.
Okay, thank you so much. I think we are really running out of time, so we might have time for just one question. Katie, if the primary endpoint is still applicable to women with double mastectomy, why not include them in the primary study? The just would not contribute to the secondary endpoint.
That's a good point. I mean, that is one consideration too, since initially in the concept we discussed when we first presented in the spring at one of the monthly calls, we were using change in the imaging biomarker, the CNN score, as the primary outcome. So it's reasonable to, change the exclusion criteria a little bit more to be more inclusive. But we can talk more about that.
I would say quickly, though, that we typically don't recommend chemo prevention in women who.
Oh, that's true. Yeah.
Bilateral mastectomy.
Oh, yeah, that too.
Really
Yeah. Thanks for taking a step back and looking at that.
Wonderful. Thank you very much. I think we have 2 and 3 more very brief presentations. So Dr. Neuhauser.
Hey, great. Thank you, Banu. So our next presenter is Dr. Andrew Brenner, and he is going to give us an update on his R01 submission.
Yes, this will be pretty brief. This is based on our preclinical findings and a lot of other people's findings that obesity drives inflammation, and those inflammatory cytokines drive the aromatase promoter, resulting in increased aromatase expression. And we, as well as others, have shown increased aromatase expression within that correlates with BMI. And so we've gone back and done some retrospective studies looking at COX-2 inhibition, as well as some prospective pilot studies that suggest that that might be able to prevent aromatase expression in the obese patient population. Next slide. So this is really the key schema for the study. So any woman with either invasive or pre-invasive cancer that is ER positive, HER2 negative with an elevated BMI, who's planning to undergo adjuvant endocrine therapy with aromatase inhibitor and is postmenopausal will be eligible for the study. They'd have a compliance run-in, they'd be randomized, and prior to starting either aspirin or placebo, they would go undergo biopsy of the contralateral uninvolved breast. So they would have already completed chemotherapy and radiation if that was applicable to their particular case of the involved breast, and the contralateral breast would undergo biopsy. And then they would also undergo serum sampling, and then they receive 12 months of either the placebo or aspirin together with their aromatase inhibitor of choice for 12 months. And then we repeat the biopsy of the contralateral breast and serum sampling. And then it kind of shows it in a different fashion over here on the right to also include the interim serum sampling. This was overall well received. We kind of bounced around. Our initial score was at 9th percentile. And of course, that was right at when they dropped at the 8th percentile and quickly changed their minds. And so we are resubmitting, or we resubmitted, and we're expecting that back it will be reviewed on October 28th. The key issues that were brought up by reviewers, one of them was the pilot data. There was a little bit of misunderstanding in terms of we had some immunohistochemistry data in there that we kind of showed this was conceptual. And then after that, we used the same technique that we're going to be using in this study, which is RNA-based expression profiling. And so, so we kind of de-emphasized the immunochemistry data, emphasized the RNA-based data, and then also cited Andrew Dannenberg's data as well, which further confirms what we saw. Andrew Dannenberg's group saw exactly the same thing. So I don't think there's any question about whether the primary endpoint would be valid or not. And then they wanted some additional justification of the dose, why we're doing 325 milligrams beyond what ABC is doing. And then there was some other question about the approach, particularly intent to treat, and they wanted us to move the biopsy prior to randomization to decrease the amount of dropout and to make it more statistically sound. And so we did do that. And I think we addressed pretty much all of their critiques. I'm not sure there's much more we can do at this point. So we're keeping our fingers crossed, and we'll see. Next slide just shows, again, the timeline.
Great, thank you so much, Dr. Brenner. We probably have time for one quick question. Okay, I don't see any in the chat. I'm very hopeful for this. It sounds like you addressed everything quite well, and I think using the RNA-based assays and emphasizing that hopefully will go over well with reviewers. So we're looking forward to hearing the results of that and hope that it will be positive. I think it's really going to be good. So now I'm going to turn it back over to Dr. O'Brien.
Thank you. And our last presenter will be Jason Zell. He, as mentioned at the beginning, was going to join a little bit later. So Jason, can you give us an update on S0820?
Yeah, thank you so much, Benu. Can you go to the next slide? So yeah, I really want to talk to everybody about this study. We have now 320 patients. Actually, as of today, 321. I am concerned about the slow rate of accrual. During the last 6 months, we've had 8 registrations, although when I notified the team about this, we just had 5 in 6 months. So we're supposed to have 5 per month. This study is not meeting its accrual goal at all. At this rate, I mean, it would be 3 to 6 years, even if we met the accrual rate or just less at the current rate before the study completes. And so I have concerns about that. The other thing is, I will tell you this week, we've had 3 registrations since I kind of expressed some accrual. So it is part of the problem with this study that sometimes these accruals come in batches, but over the summer, and really since COVID, it looks like we're averaging about 3 per month. Now, what I want to propose, and we can discuss this at the regular meetings, the monthly meetings, I propose that we either close the study down completely, we just let it keep going as is, since there's no competing trial out there, the question's still relevant, or we modify the statistics. Joe Unger, as our chief statistician, I will remind everybody, this proposal is focused on finding a 50% reduction in our primary endpoint, which is listed there. My mentor in his, Dr. Mason's in his study with a similar number of patients, 267 patients, they actually found a 92% difference. So we are overpowered already. It may be something like a statistical reworking to a 60% effect size, given the justification of the prior study, that we could work with. That might make this study feasible in a 2-year time frame or something like that, even at a slow accrual rate. But we don't have those numbers yet. So I really just want to put this out there for discussion and probably discuss more with the NCI and any of you offline.
Thank you very much, Jason. I don't see any questions. If there are any, please, email us and Dr. Zell as well.
Can I just ask a quick question?
Yes, Dom, you can.
Sorry, I've got this background light, so I've been keeping my camera off. Anyway, maybe for anybody from the NCI that's on the call, if it would help to have like a call about what the best course of action is. I don't know if our colleagues are still on from the
Leslie
NCI.
was on.
Leslie was on before, but it might be good before making a decision just to either set up a call with them. Here Marge Good says that a call would be good. So maybe the best course of action would be, for the study team, I'm happy to join, to set up a call with the NCI about the best strategy, since so much time and effort has gone into this trial.
Yeah, and Leslie just messaged as well that a call would be a great idea. Yeah. Okay, great.
Yeah, thank you, Don. Thank you.
Sorry, great, thank you, wonderful. Okay, right before we close, we would like to give a very brief moment to our patient advocate, Cheryl Jernigan. She has the big plans and big presentations, which she will do in the subsequent meetings, but she's going to give us a little glimpse, a short glimpse of what's going on.
Real short, hopefully. As of this meeting, this fall meeting, we have 2 new community advocates. One representing rural residents, the other one representing LGBTQ, and that gives us 10 community advocates. What I'll be talking about at our meeting in November, hopefully, will be an overview of the Patient Advocate Committee, the roles and differences between research advocates and community advocates, and how to engage research and community advocates in light of the recently released Team Science Module 6, which is focusing on improving diversity and representativeness of clinical trial participants. So that's my brief report.
Thank you, wonderful. Any questions for Cheryl?
I'll just reiterate, as Cheryl mentioned, she'll be giving a lengthy presentation at our next prevention teleconference, which will be the first Monday of November. So we look forward to that.
Wonderful. There's one question that came from, do we know reasons for poor accrual for PACEs? I think that's a very long answer, but is there a short answer, Jason? He may be signed off.
He may have had to leave.
Yeah, he had to, I think, maybe go back to clinic. Okay, in that case, I would like to thank everyone for their participation and wonderful presentations, and we'll give the podium to Dr. Neuhauser so that you can do the closing also.
Yeah, thank you everyone for attending our virtual committee meeting today. We had a very robust agenda with a lot of interesting studies going on. We really hope that we will be able to see you in April here in Seattle, and we look forward to that. And in the meantime, stay safe and healthy. And we know that we'll have follow-up of many of our ongoing studies at our monthly teleconferences. So thank you, everyone, and see you soon.
Bye, thank you.
Bye.